Hi everyone, welcome to the Karmanos Lung Cancer Prevention and Screening webinar. I'm Dr. Hirva Mamdani. I'm a medical oncologist at Karmanos Cancer Institute. My specialty is in the treatment of lung cancer, and I'm also the director of lung cancer screening program at Karmanos. In addition, I lead a number of clinical trials to help develop new treatments for lung cancer. Today, I'm joined by three great speakers, Dr. Nithin Thummala. Dr. Thummala, if you can wave to just make sure everybody knows who you are. Dr. Thummala is an assistant professor of radiology and oncology at Karmanos Cancer Institute. He specializes in reading scans done for screening, diagnosis, and follow-up of cancer, including lung cancer. He will give us an overview of what a CT scan done for lung cancer screening looks like, and he will include some examples. Then we have Laura Manta, who is the coordinator and one of the strongest pillars of our lung cancer screening program at Karmanos. She will walk us through the details of eligibility and process of screening. And finally, we have Dr. Sean, who has graciously agreed to share her experience with us about our lung cancer screening program. And we will have a dedicated time at the end of presentation for a Q&A session. This session will be more for general questions regarding lung cancer prevention and screening, and wouldn't necessarily include details of a particular case or a diagnosis. Just a few housekeeping items to avoid any unexpected background noise, as we all know can happen. All attendees are muted. This is a live webinar that is being recorded and will be housed on our karmanos.org website. And to ask questions, please type them in the chat box and we will get to them at the end of presentations in our Q&A session. So to begin the webinar, I want to walk us through some of the facts about lung cancer, its burden in our society, and if we can do anything to prevent it and detect it at an earlier and hopefully curable stage. We all know that cancer is a global challenge. What sets cancer apart from other conditions such as heart disease is that its impact is not only limited to the health of a particular person. Cancer's ramifications affect our families, community, and society in general, and it has a lot of emotional and economic impact as well. Globally, cancer accounted for 1 in 7 deaths in 2005. A decade later, in 2015, cancer accounted for 1 in 6 deaths. And we are expecting it to account for nearly 15 million deaths in 2035 if there are no major advances in the prevention and early detection. The major culprit for these numbers is lung cancer. The blue graph on your left shows that lung cancer is the second most commonly diagnosed cancer in the world, and it accounted for nearly 2.2 million cases in 2020. The graph on your right shows that lung cancer is the leading cause of cancer-related deaths and accounted for nearly 2 million deaths in 2020. What is more striking here is look at the second most common cause of cancer-related death, which is the colorectal cancer. And it accounts for less than half of cases of death compared to lung cancer. And these numbers hold true in the United States as well. In 2021, we expect lung cancer to continue to be the second most commonly diagnosed cancer in men and women, and to continue to be the leading cause of cancer-related deaths. This information brings forward a very important and personal question. What can we do to do better? In 21st century, these numbers are not even nearly where we want it to be. Can we do anything to prevent this deadly cancer? And can we do anything to improve the outcomes of cancer once somebody is diagnosed with it? To learn about it, let's just see what lung cancer means. Let's take a normal lung cell and look at it underneath the microscope. Every cell of our body has a genetic material called DNA, and DNA is made up of building blocks called genes. Genes are essentially the blueprints of the function and growth of a particular cell. If there is any glitch in this blueprint, or what we call as a mutation in the DNA, it leads to uncontrolled growth of the cells, which become malignant and cause cancer. If cancer is not diagnosed and treated at an early stage, the cancer cells will make their way into the lymphatic system and through the bloodstream to many different organs, such as brain, liver, bones, adrenal glands, etc. And this is where we call it a metastatic cancer or stage 4 cancer. What causes the glitch in the blueprint? Well, 80 to 90% of the cases of lung cancer can be attributed to cigarette smoking. The chemicals in the cigarette smoke interact with the DNA material of the lung cells, and they cause that glitch in the blueprint, which then causes lung cancer. In the remaining 10 to 20% of the cases, there are other factors that are responsible for lung cancer, such as environmental exposure to radon, secondhand exposure to smoke, and in some cases, genetic abnormalities. So what does this tell us? We may not be able to control our genetics, and we may not be able to change the environmental exposure without any major changes in the policies, but we can prevent majority of lung cancer cases through smoking cessation. And it's rightly said, prevention is better than cure. It's very hard to quit smoking, but there are many, many resources available. And here are some of them, including some of the websites. There's a quit line, and there's a really cool app made by CDC, which you can use on your smartphone. Once you quit smoking, the health benefits start almost immediately, as soon as 20 minutes after your last cigarette. And several weeks to months later, you will feel that your lung function is improving. Your cough and shortness of breath will improve. Approximately 1 to 2 years later, your risk of heart attack will go down. 5 to 10 years later, the risk of cancers such as head and neck cancer and bladder cancer will go down to half. And 10 to 15 years later, the risk of lung cancer will drop to half of that of somebody who is still smoking. So I think we all can agree that smoking cessation is the best preventative strategy for lung cancer. But the reality is that we can't prevent each and every case of lung cancer. And what makes lung cancer such a deadly disease is that majority of patients are diagnosed when they already have metastatic or stage 4 disease, when the outcomes are still unfortunately poor. Only about 17% of patients are diagnosed when lung cancer is still stage 1 or localized, when we have the maximum chance of curing it. So our goal is to detect the cancer when it's still here and not here. And the way we do it is through the help of lung cancer screening. This has been proven scientifically through major clinical trials. The first trial, called National Lung Screening Trial, or NLST, was reported in 2011. In this trial, over 53,000 people who were considered to be at high risk for lung cancer were included. The high risk was defined as anybody who is between the age of 55 to 74, at least 30 pack years of smoking history, and either current smoker or they had to have quit within the previous 15 years. We will get to the details of how to calculate pack years a little bit later in the presentation when Laura reviews the eligibility for screening. Essentially, in this trial, people were divided into 2 groups. One group received annual CT scans for 3 years, and another group received only chest X-rays. And the study showed that people who underwent low-dose CT scan on annual basis had 20% reduction in the risk of death from lung cancer. And in plain words, lung cancer screening saved lives. Another study called Nelson Trial included nearly 16,000 people, mostly in Netherlands, who were considered to be at high risk of lung cancer. The definition was only slightly different from the earlier study. And again, the people were divided into 2 groups. One group got periodic CT scans and another group didn't. And again, at the follow-up of about 10 years, the study showed that the screening group had lower lung cancer mortality compared to the people who did not get screening. So again, lung cancer screening does save lives. And based on these data, now we are strongly recommending that eligible people should undergo annual low-dose CT scan for lung cancer screening. This recommendation has been endorsed by the United States Preventative Services Task Force, as well as major health societies. So from here, I will hand over the presentation to Dr. Thummala, who will review the details of low-dose CT scan for lung cancer screening. Dr. Thummala.
Are you able to hear me? Thank you very much, Dr. Mamdani. Hello, everyone. My name is Dr. Thummala. First of all, I would like to welcome you. Thank you for spending your time for this webinar. My talk is mostly going to focus about the radiology aspect of the lung cancer screening program. So mostly I'm going to talk about the low-dose CT examination itself and how we evaluate the CT examination. The first part of the exam is getting the CT examination. Here at Karmanos, we use a multi-detector CT scanner. For this examination, no patient preparation is required, no fasting is needed. Also, no IV contrast is administered for this examination. So you will not need to get an IV line when you come into the radiology department. The whole process is pretty quick. Once you arrive in the the radiology department, you'll be checked in, asked a few simple questions, making sure you don't have any symptoms. And then once you're on the table, once you're positioned into the CT scanner, the technologist will ask you to take a deep breath and hold it, during which time the images are acquired. The time of acquisition of images is only about 10 to 15 seconds. After that, you'll be done with the examination portion of the low-dose CT exam. One of the questions and concerns that most patients often have is about radiation exposure. The radiation exposure for this examination is very low. It's about 5 times lower than a traditional or conventional CT examination, hence the term low-dose CT examination. The radiation dose is less than 3 milligrays for an average patient. Most often, it's much less than 3 milligrays. Just to give you a reference, the average background radiation that we all receive annually is about 3 to 5 milligrays. So this is much less than that. Furthermore, the benefits of getting this exam outweigh the very limited risks of radiation. So once the images are acquired, the images are sent to the radiologist for interpretation. There are very specific criteria for who can evaluate the low-dose CT examination. One of them being is that the radiologist has to be board certified or board eligible. Here at Karmanos, we're all board certified radiologists. The goal of doing this low-dose CT examination is to find these very early lung cancers. We do that by looking at trying to find concerning nodules or suspicious nodules. So when we look at the images, we're looking at each individual nodule very carefully. We're looking at the size of the nodule, we're looking at the shape of the nodule, the density of the nodule, and then we score them. We give them a final score. Once we do that, next we need to formulate a report. To formulate a report, we use something called LungRADS, which I'll be talking to you about in the next couple of slides. The LungRADS was a system that was formulated by the American College of Radiology to help, so we all use the same language. So every nodule is, we use the same language, and also helps us that when we report a lung nodule, they go through the same management pathway. So just to give you a brief overview of what LungRADS categories are, The first one I want to talk about is category 0, which is usually an incomplete exam. Either the entire lungs were not covered, or the patient has outside examinations that we need to compare with. The next two categories, categories 1 and 2, are both negative screening examinations. So what this means is that nothing needs to be done. The patient you would just have to come back in about 12 months for another low-dose CT examination. The next category is category 3, which is probably benign. What this means is that we see a nodule, it is not very concerning, but we still want to keep a close eye on it. So rather than bring you back in 12 months, we would like to bring you back in 6 months to make sure that the nodule hasn't changed. And as you can see as the categories increase, the risk of cancer increases. Categories 4A and 4B are concerning. 4A is suspicious and 4B is very suspicious. The risk of cancer is greater than 15% in 4B. For these, the way we manage them is if we are not very concerned, we would do a very short-term follow-up CT examination. The more concerned we are, we'll either get a PET scan, or if the nodule is big enough, we may forego these prior studies and get a sample. Also in Karmanos, all 4A and 4B nodules are evaluated or are discussed in a multidisciplinary conference where there is a thoracic oncologist, there's a thoracic surgeon, radiologist, and pathologist. We discuss these cancers and decide on a plan of action. Sometimes on a low-dose CT examination, we may find other significant findings that are not cancer-related. For example, we may find coronary calcifications, we may find incidental breast nodule. When we see these, we usually give a subcategory S to signify there's something else that's significant in the exam. So now that we've given you an overview of LungRADS categories, I wanted to show you some real-life examples. This is to show you the importance of screening. The first case is a 65-year-old woman with 40 pack-year smoking history. Laura later on will be explaining to you what pack-year means. So the first low-dose CT examination, this is the same patient, same images, just one is blown up. The black is lung. The abnormality is this right here. This nodule that has irregular margins, which is very concerning. So this nodule measured about 17 by 13 millimeters, and this makes it a 4X nodule. So it's even more concerning than a 4B nodule. And subsequently, this patient underwent a biopsy, which showed that this was lung cancer and was treated with chemotherapy and radiation therapy. Case number 2, 58-year-old male with 42 pack-year smoking history. So on the initial screening examination, we found a small nodule that was about 5 by 6 millimeters. Based on the criteria we talked about earlier, this fell into LungRADS category 3. And we talked about this. This patient would come back for a 6-month follow-up scan to make sure this nodule is stable. Unfortunately, in this case, when the patient came back in 6 months, this nodule grew. This grew from 5 by 6 millimeters to 11 by 7 millimeters. And based on the size, this would be a 4B nodule. Patient ended up getting a PET scan eventually. The PET scan showed mild uptake, and then a biopsy, which showed lung cancer. And this patient underwent surgery for this lung nodule. This is one of the benefits of doing lung cancer screening, where we can find them when they're so small that these patients can still undergo surgery. My last case, this case highlights a very important point. 77-year-old woman with 50 pack-year smoking history. She had a screening study done in 2015, which was a negative screening exam. There were no concerning nodules. She comes back a year later, and on this exam, we can see there's a small little nodule. I'm showing you the same slice on both ears. Small little nodule measuring 9 by 9 millimeters. Based on the size and the way it looks, this nodule is a 4B, which is again a very suspicious nodule. And the next step up in the workup, the patient had a PET scan. And on the PET scan, we can see this nodule takes off glucose. This is a hot nodule, which is concerning. And then the patient had a biopsy of this nodule. The biopsy showed small cell lung cancer, localized, and the patient underwent radiation therapy and is doing well as of today. And with that, I would like to thank you for your time.
Thank you, Dr. Thummala. That was very, very informative. And I think, the take-home point from here is, while it is very important to begin screening, it is equally important to continue the screening at a regular interval, because the first scan may be normal, but the subsequent scans may show abnormalities, which may turn out to be lung cancer. So thank you so much. That was great presentation. And we will now move on to Laura, who will walk us through the lung cancer screening eligibility and the overview of our program. Laura, you're up.
Just got to unmute yourself there, Laura, in the far left corner. That's it. On the very bottom, far left corner, unmute.
I found it. Am I unmuted? Can you hear me? Yes? Okay.
You're great.
Perfect. So thank you so much, Dr. Mamdani. I also wanted to thank everyone for joining us today. My name is Laura Mantha, and I am a research nurse and coordinator of the lung cancer screening program at Karmanos Cancer Institute. My talk today includes a short history and overview of our lung cancer screening program, the eligibility requirements for lung screening, as well as a review of our screening process. So first, I'd like to give you a short overview of our program. Although we've been offering lung cancer screening at our facility since 2013, and that was based on the results of the National Lung Screening Trial that showed a lung cancer screening using low-dose CAT scans in high-risk adults help save lives by detecting lung cancer early. It wasn't until 2015 that we actually developed our lung cancer screening program as it is today. And this was based on the U.S. Preventative Service Task Force, who recommended lung cancer screening as a preventative service using once a year low-dose CAT scans as a screening test for lung cancer. And due to this recommendation, Medicare, as well as other private insurance companies, agreed with the recommendation and started to provide lung cancer screening coverage as a preventative service benefit to adults who met certain high-risk criteria. Our program offers lung cancer screening at 2 locations, our main campus in Detroit and at the Weisberg facility in Farmington Hills. Karmanos Cancer Institute is designated as a lung cancer screening center by the American College of Radiology and also a screening center of excellence by the GO2 Foundation for Lung Cancer. So on this next slide, I've briefly listed the components of the lung cancer screening program, but I will go through them one by one a little later in the presentation. So the process starts with a questionnaire to check for screening eligibility. And next, we provide education about the screening program itself, including how the process works, as well as benefits and risks of screening at a screening visit with a Karmanos healthcare provider. After this discussion, an order for the screening scan is written and the test is completed on that very same day. The next 2 components, the image acquisition and the image interpretation, have really already been covered by Dr. Thummala. So then we have communication of the results of the screening scan back to you. And finally, if any abnormality is found, arrangements are then made for any follow-up that may be required. So who should be screened and what are these high-risk criteria that I mentioned earlier? So to be eligible for lung cancer screening, if you have Medicare or Medicaid insurance, you must be between the age of 55 and 77. You also must be a current or former smoker who has quit within the last 15 years and have a smoking history of at least 30 pack years. Lastly, there must be no signs or symptoms of lung cancer. And what I mean by this is that you don't have any new or any worsening shortness of breath or cough from your baseline or any coughing up of blood, for example. And these eligibility criteria I've listed are very similar to the original criteria that were used in the National Lung Screening Trial. So if you look at the diagram to the right of the screen, you will see how we go about calculating pack years of smoking. So the number of years you've smoked is entered into the first box at the top and then multiplied by the average number of packs of cigarettes smoked per day. And this number will then equal the number of pack years of smoking. So some examples again to the right there. If you smoked 1 pack a day times 30 years, that would equal 30 pack years. And also if you smoke 2 packs a day for 15 years, that would also add up to 30 pack years. So Medicare started covering the cost of screening as a preventative service benefit with no copay or cost sharing to you as of February 5th, 2015. Lung cancer screening is also covered by most commercial insurers from age 55 up to age 80 if all those other eligibility criteria I just mentioned are met. And again, in most cases, it is covered as a preventative service with no copay or cost sharing to you, but we do recommend that you check with your health insurance plan to make sure it's a covered benefit, as not all plans are the same and may have different coverage rules, and we can help you with this if you need assistance. So the next slide provides some information on how to contact our lung cancer screening program. To request lung cancer screening, you can either call our toll-free number at 1-800-527-6266, or you can email us at screening@karmanos.org, or go onto our website at karmanos.org and fill out our online request form. There are also additional resources and information about lung cancer screening on that website. So once we receive a screening request, our staff will contact you and complete the eligibility questionnaire. And if eligible, the screening process will move forward as I will describe for you in the next slide. So finally, I'd like to take you through the steps in our screening process. Starting at the top, when we receive a call or an email requesting lung cancer screening, a trained staff member will then review eligibility with you over the phone through a short questionnaire. And then once this questionnaire is completed, it is sent to the coordinator, that's me, who will then call with an appointment for a screening visit as well as for the low dose CAT scan. And the purpose of this visit again is for a discussion with the healthcare provider about the program itself, benefits and risks of doing lung cancer screening, as well as for providing smoking cessation counseling. And this visit is required only one time, and that's before the first CAT scan for screening is completed and not in subsequent years. So our physician assistant, Kimberly Belzer, does perform most of these screening visits for our program. At the time of visit, a prescription for the CAT scan is provided, and then you will then be directed to the CAT scan department to have your screening scan. And once the CAT scan is done, your visit for the day is complete. After the radiologist reviews the scan, it is reviewed again by our program director, and then the results are communicated back to you over the phone and in the form of a follow-up letter to you and your primary care physician if you have provided that information at the time of enrollment with us. If the results are normal, you will continue with annual screening. You will receive a reminder call about 4 weeks before you're due for your next yearly CAT scan, and we will confirm eligibility again at that time and schedule the next scan for you. If an abnormality is found, the results will be reviewed and discussed in our multidisciplinary team meeting, as Dr. Thummala described, and the final recommendation of this group meeting will be communicated back to you via phone, and any recommended follow-up will then be arranged for you at that time. And I want to thank you very much, and I would like to turn it back over to Dr. Mamdani, who will provide a brief summary for you.
Thank you, Laura. That was very informative. So I wanted to just share my screen for a little bit here and go over what we learned during this webinar. So we saw that lung cancer is the leading cause of cancer-related mortality in both men and women. Smoking cessation is the best preventative strategy for this cancer. Early detection through screening low-dose CT scan has been shown to decrease mortality from lung cancer in people with heavy smoking history. And annual screening with low-dose CT is recommended by USPSTF and other major healthcare societies. The limitations, however, are that we don't have enough data on some of the other patient populations. So for example, people with non-traditional risk factors, such as exposure to secondhand smoke, they are at a high risk of developing lung cancer compared to people who didn't have secondhand exposure to smoke, but we're not able to screen them at this time, which is very unfortunate. And the reason for that is they weren't included in one of the bigger trials that were done to establish the role of low-dose CT. So this tells us that there is so much more for us to learn and do in this regard. Here are some of the websites that you can use to gain more resources and more information about lung cancer screening, guidelines, and some more information on the material that we covered during the webinar. So from here, I'll turn it over to Dr. Sean, who, as I said earlier, has graciously agreed to be here. Dr. Sean has been enrolled on our lung cancer screening program, and she is here to share her experience. Thank you, Dr. Sean, and the floor is yours once I stop sharing the screen.
Yay! Thank you, Dr. Mamdani. Exquisite, exquisite. Here's the thing. This webinar is probably going to take longer than the actual screening. And I had Laura. Laura was my coordinator. I am not an oncologist. I am a patient. So I'm here as a patient. And there was a tipping point for me to get this done. I'd been thinking about lung cancer screening. So many people in my family had lung cancer, died from lung cancer, died from many types of cancer. My tipping point was when my husband said to me, this was last January, my mother died. I lost my mother, my sister, and my father all to cancer just before COVID. I was the caregiver. It's a little emotional for me to share this. And my husband said to me, he said, sweetheart, you smoked for 30 years. I'm 56, about to turn 57. I meet all the criteria. I have no symptoms. Would you've been talking about this, would you do this for me? Because I know what you went through caregiving for all these family members. So I'm hoping what I share with you tips you over to just go get the frickin' screening. Sorry guys, a frickin' is not allowed. That's how I talk. And it was an exquisite experience, from the phone call, being with Laura, understanding what I would be going through. I had to hold my breath. I think mine lasted 5 seconds. I was in and out of Karmanos in about 40 minutes. The staff was exquisite. I was scared to go. I was calmed and soothed and even treated lovingly. And probably Laura was the most loving as the coordinator. Laura, you're the only reason I'm here. I'm like, of course I'd come on and share this experience. The thing is, this is preventable. And we saw all these stats from Dr. Thummala, from Dr. Mamdani. This is preventable if you catch it early. It doesn't hurt. The one thing that I had fear about, is that 20% of the time there'll be false positives. So when you get your screening, I got it so fast, I thought, oh, I might have to wait a week. And Laura says, oh no, we're not going to make you wait in any grueling time constraints or anything. They called me back, like it was a Friday. They called me back on Monday with my results. So I only had those 2 days of like this. I came back at number 2, which meant I probably have benign nodules, little tiny nodules, and I'm approaching this like a mammogram. This is like a mammogram. I've already got it on my calendar to go next year. There's nothing more for me to do except come back next year so they can do a comparison, because I have that baseline done. The biggest favor you can do yourself, especially if you're a former smoker or you think you might have the possibility of this, is to go get your base and just be on top of it and do the self-care. Not only do you owe it to yourself, you really do owe it to your family, because cancer impacts an entire family. And now we're at the stage of technology that we actually can do something when we catch it early. So I'm in the game of catching it early, and I hope this tips you over to go through this process, because I would use the word loving. It was a loving process. And I appreciate you guys inviting me to share my experience.
Thank you, Dr. Sean. That was very powerful and very personal. I think most of us would agree that when we're in the field of medicine, especially in the field of oncology, it's very gratifying to know that we're able to make a difference for somebody. So thank you for sharing that.
My pleasure.
All right, so I think it's time for us to move to our Q&A session. I already have 2 questions in the chat box. I'm going to read them and we'll direct to whoever is most likely to be able to answer those. So the first question is, I think Laura can take this. So the participant is asking, I've not smoked in 50 years. I have lupus and have had pneumonia several times. Should I be screened for lung cancer?
So, for the screening eligibility, you actually have had to have quit smoking within the past 15 years. So the fact that it was 50 years ago, you wouldn't be eligible for lung screening at this point. And one of the reasons too is because as you get further away from your lung cancer or your smoking history, the risk does go down as you remove, you get yourself further from that. So that one is the reason why you wouldn't be eligible though, because you would be past that 15-year mark.
Thank you, Laura. The next one is, as far as the benefits of smoking cessation, is the timeline of the benefits the same for, say, a person who has smoked for 40 years and a person who has smoked for 10 years? That's a great question. We know that some of the benefits, the timeline is not different depending on the duration of smoking or the amount or the number of cigarettes you have smoked. But the lung cancer risk, the magnitude of benefit that you get in terms of lung cancer risk is a little bit lower at a particular time frame if you smoked, let's say, for 40 years compared to 10 years. So let me give you an example. So let's say somebody has 10 pack years of smoking history and they smoke today. Their risk for lung cancer declines a little bit faster than somebody who has 40 pack years of smoking history. Having said that, it's never too late to quit smoking because we do want the risk to go down, at least at some point in time. And you saw the benefits immediately after you quit smoking. You start getting health benefits, which are not just limited to lung cancer risk. So the next one is, what are some of the most common misconceptions about lung cancer you have personally witnessed? And from your personal research, how does vaping affect the health of the lungs? Has there been a connection between vaping history and lung cancer? This is a great question and very time relevant. So let me answer the vaping part of the question first. Because vaping is a relatively new thing, we don't have any long-term data on how it affects the cancer risk. But we know that people who vape have a higher risk of developing lung cancer compared to people who have never smoked and never vaped, which means that the chemicals in the steam that comes out of the e-cigarette or the vapor, it does damage the DNA of the lung cells. So there is a risk. We don't know how much it is. We don't know how long you have to be vaping to develop lung cancer. Those are the research questions. There is, however, a very strong link of vaping with damage to the lungs in terms of causing acute and chronic inflammation in the lungs, which can sometimes be more debilitating than developing lung cancer. So at this point in time, we don't necessarily recommend vaping as an alternative of smoking. It is always, always, always recommended to quit smoking without the help of e-cigarettes. To answer the second part of the question, what are some of the most common misconceptions about lung cancer you have personally witnessed? The first thing I can think of is one thing that I hear commonly is lung cancer feeds off of sugar. So you should stop eating sugar if you're diagnosed with lung cancer. That's not true. Every cancer, especially lung cancer, needs carbohydrates. It needs sugar to grow, but that has nothing to do with the sugar that you consume in your diet. The lung cancer, or any cancer for that matter, is going to take the sugar from your body no matter what you eat. So it's recommended that you continue to eat a good balanced diet with good amount of calories to give your body enough strength to fight it. Any other misconceptions or myths that you guys can think about? Dr. Thummala, Laura, Dr. Sean? This is the most common one that I've heard. I have two other questions here. I've had breast cancer and been treated. I've been tested and have a small nodule on my lung. I've had 2 scans, and after the first one, they found the second nodule. I went back 6 months later, and the first one is the same size, and the second one was seen. Should I continue to have the small nodule checked? Dr. Thummala, do you want to take this question?
I'm a little confused about the question. The first scan showed 2 nodules. The first scan only showed 1 nodule.
So it sounds like the first scan showed 1 nodule, and when they did a second scan, they found a second nodule.
Okay.
And then there was a follow-up scan 6 months later, which showed that the first nodule was same size, and the second one was also seen. I don't think we have a clarification on the size of the second nodule. So the question is, should you continue to have them checked?
I would, only because you also have a history of breast cancer. There's a lot of factors here. I need to know the size of the nodule and the time frame between the first scan, second scan, and third scan. But given history of breast cancer, I would absolutely follow up on those nodules.
Oh, and there is a clarification now. So the second one, a second nodule was not seen at the 6-month scan, but the first one was still present. And I think our answer still remains the same, that we should continue to check them out.
Yeah, the longer the nodule stays stable, the more likely it's benign. So just keep following up that nodule.
Mm-hmm. Thank you, Dr. Thummala. The next question we have is, what is the difference between small cell lung cancer, non-small cell lung cancer, and just lung cancer? Is there a difference in the treatments? So there are major differences between small cell and non-small cell lung cancer. They are biologically very different disease. Small cell lung cancer is a very, very aggressive type of lung cancer. And to just, put it in context, sometimes it grows from day to day. The size increases. If you scanned, let's say this Monday, and you did another scan next Monday, the size would be different. Non-small cell, on the other hand, it is still an aggressive type of cancer, but the growth rate is not that fast. And because these are 2 biologically different diseases, they are treated differently, and there are differences in prognosis and outlook as to what we expect with the treatment. The second question is, medical and recreational marijuana are now approved in Michigan. Can you discuss marijuana effects on the lung tissue, and does it cause lung cancer? Great question, and another timely question. We don't have any data at this point to show the link between marijuana and lung cancer. Having said that, it's mostly because this is a very new thing, just like vaping. Smoking marijuana, and for that matter, smoking anything, will cause damage to the lung tissue. So there is a risk of, again, acute and chronic, or short-term and long-term damage to lung tissue if you smoked anything, including marijuana, so that is not recommended. There is some ongoing research about health benefits of other forms of edible marijuana. And again, we are in very early stages to recommend for or against that. I think that's it. We don't have any other questions here in the chat box. I think we will give a couple more minutes just to make sure if there are any questions, if they come up. We have a feedback in the chat box. Great presentation. Well, thank you so much. We really, really, really enjoyed this webinar. I want to thank each and every one of you for taking the time out of your busy schedules and attending this. I'm very thankful to Dr. Sean, Dr. Thummala, and Laura for sharing their expertise and experience here. Just to remind everyone that this was a live webinar and it was recorded. So if you want to go back to the presentations and listen to them again, they will be housed on our website. And please feel free to share the information with your friends and family or whoever you feel would benefit from the information. We all know how the year of 2020 has been so challenging for all of us. And as we begin this new year, our hope through this webinar is to give you guys a tool to take a step forward towards preventing lung cancer and detecting it at an